Good day, everyone. This is Chris Nordon, the Executive Director of the Center for eHealth at the Patient Center Primary Care Collaborative. It's a real pleasure to welcome all of you to today's webinar. It's another in our series of continuing presentations that explore the many interconnections between health information technology and the patient-centered medical home. Today's presentation marks a special anniversary in the Office of the National Coordinator's Beacon Community Program. The Beacon community is celebrating its first 5 years of improving healthcare through health information technology, and we're honored to have a team of speakers from the Crescent City Beacon community in New Orleans who will tell us more about their use of innovative HIT solutions to implement the NCQA PCMH model. One special notice, if you were able to attend our Spring Stakeholders Conference last month, or if you missed it, mark your calendars now for October 25th. The Fall Stakeholders Conference will be held in Chicago, a new venue for us, first time outside of DC, and hope to see many of you there. There'll be more information about the Fall Conference shortly on the PCTCC website at pctcc.net. Regarding the process for question and answers today, if you look over to the right-hand side of your menu bar, there's a drop-down box where you can input questions at any time. We're going to hold the questions until the close of the webinar or the end of the presentations, and then direct them to the appropriate speakers for responses. On another note, today's webinar, both the slides and the audio, will be available on pctcc.net/media by the end of the day tomorrow. If you want to go back and pick up on a thread that you may have missed, or if you want to refer your colleagues to the great presentation that you heard today, that resource will be available by the end of the day tomorrow. So without further ado, I'd like to introduce Craig Brammer, the Deputy Director of the Beacon Community Program at ONC. Craig was formerly with the Department of Public Health Services at the University of Cincinnati Academic Health Center, and Craig will set the stage for today's discussion and begin the introduction of our distinguished panel of speakers. So thank you, Craig.
Sure, Chris. Thanks very much. It's great to be with you all, and we appreciate the invitation here to just take a sneak peek into some really exciting work that's happening across what we refer to as Beacon Nation. Wanted to start by just, well, first of all, Chris, let me correct one thing that you said. We've only been at this for 2 years, not 5 years, so the work you're going to hear is really fast-moving. They're well into their work, but you know, 2 years goes pretty quick. This is a short program. It's a 3-year initiative funded through the HITECH Act. You know, the Office of National Coordinator for Health IT and our colleagues at CMS are deploying a lot of programs and activities associated with HITECH, including obviously meaningful use, but also a lot of work around standards and interoperability, privacy and security, and health information exchange, among others. We look at this Beacon Community Program as an opportunity to bring all that to life in certain neighborhoods across the country. There were 17 communities that were selected from Maine to Hawaii. They each received an average of $15 million over a 3-year period. They include large integrated delivery systems like Geisinger, Intermountain, and Mayo, and then other parts of the country that are more disaggregated, like Indianapolis or Spokane, Washington. In all cases, these communities had demonstrated a higher than expected adoption rates of electronic health records and a trajectory of community-level improvement that most typically included quality measurement and improvement, payment reform, obviously health IT, and other activities, and in many cases, patient-centered medical home activities. We're really excited that as of late, a few weeks ago, of the 7 Medicare Comprehensive Primary Care initiatives, 2 are Beacon communities, Grand Junction, Colorado, and Cincinnati, Ohio. These folks have included medical home activities as part of their Beacon. They were doing this kind of work prior to Beacon, and this new partnership with CMS will only accelerate their work. So we're really excited about those. All communities really are using technology to lay the architecture to support a reformed payment and clinical transformation agenda. The Beacon communities really focus on 3 areas of work. We think of it as 1, build and strengthen, 2, improve, and 3, innovate. On the build and strengthen front, this includes expanding work, often pilot activities like the quality measurement activities in Indianapolis, where they aggregate payer and clinical data and produce consistent performance measures for improvement and payment. Under Beacon, that program expanded from 8 counties to statewide across Indiana. In other cases, communities are building new master patient indices, adding data layers and analytics, and you'll hear a little bit about New Orleans' long-term strategy here today. On the improve side, all communities have identified specific performance measures in quality, cost, and population health, or triple aim measures, and they report those to us on a quarterly basis. And while it's still early, we're really excited to see some impressive trend lines and are looking in the future to produce academic peer-reviewed literature about IT-enabled improvement activities underway in Beacon communities. The third area is around innovation. These 17 communities are really proving grounds for new technologies, some of which we don't know if it's going to work or not. You know, the literature's mixed on remote patient monitoring, for example. And several Beacon communities are trying to understand why and under what circumstances are those technologies most effective. A lot of exciting work around mobile health, and maybe the New Orleans guys will talk a little bit about their mobile health project. And other new predictive modeling, data aggregation strategies, new analytics strategies. So a lot of innovative work going on in the Beacon communities. And our aim now and going forward is to start talking about this great work so that others across the country benefit from this large investment. You'll see from us in the near term a series of briefs. You'll see a lot of webinars. We'll be at a lot of meetings. We look to you all to help us understand how best to articulate this work so that it's actionable. And hopefully today will just be a teaser for you, and you'll be even more interested in learning about the Beacon. So with that, let me turn it over to our colleagues and friends in the great city of New Orleans. Ebony Price-Haywood, Maria Ludwig, and Anjum Khurshid will be sharing their really exciting work. And we thank you guys for doing it today.
Okay. Thank you, Craig. This is Anjum Khurshid. I'm the Director of Health Systems at Louisiana Public Health Institute, and also the Director of the Beacon, Crescent City Beacon program in New Orleans. And I want to thank the Office of the National Coordinator for Health Information Technology and the Patient-Centered Primary Care Collaborative to have recognized the work we have pursued as a Beacon community and to have given us the opportunity to share some of our experiences with all of you. My role here is to give you a context in which the efforts for patient-centered medical home in New Orleans have taken place. We are fortunate to be joined by Dr. Ebony Price-Haywood, who is our community physician champion and helped lead this effort in the Beacon program, and Maria Ludwig, who is my colleague from LPHI and has been a key convener of the primary care building and stabilization post-Katrina in New Orleans. Both of these folks will give you more detailed information about the work related to patient-centered medical home initiatives in our Beacon program. The Crescent City Beacon Community Program is focused on reducing the burden of diabetes and cardiovascular disease in the greater New Orleans area, with the understanding that by improving population health for these conditions, we would also be improving chronic disease care system overall. The community partners have set themselves 3 major goals under the Beacon community effort. First is to reduce healthcare costs by improving transitions of care between primary care practices, hospitals, and specialty care practices, which we all know is something that our current healthcare system, because of its fragmentation, does a poor job of. Second is to improve chronic care management in primary care practices using patient-centered medical home approaches or strategy enabled by health information technology. And that's something that we will talk in more detail about today. And finally, is to use and test innovative strategies and technologies to engage the general public in the healthcare process. Next slide. So in our in trying to achieve these goals, we have been working with a fairly broad community collaborative that includes hospital providers in this area, Ochsner Children's, Toro, Tulane Hospital, and the LSU Hospital in the Greater New Orleans area. Almost all community health centers in this area are participating in the Beacon community effort. That includes federally qualified health centers. And many of these community health centers have been built up and expanded after Katrina. We also include school-based health centers. We work very closely with the Department of Health and Hospitals. We are integrated with state-level efforts like state HIE and regional extension centers in Louisiana. We work very closely with Blue Cross Blue Shield of Louisiana as a commercial payer of services, and they hold a large market in Louisiana. And then we work closely with local and state public officials. And finally, as part of our Beacon community program, we have created community advisory groups of patients and consumers to inform this process and also be our spokespersons as we think of transforming the healthcare system. So as specific examples of other activities that are taking place under the Beacon program that directly or indirectly facilitate the true patient-centered medical home role for primary care practices in our community, we have set up a local health information exchange using a product called MERT, which is an open source MPI system, and which has capabilities for a central data repository as well. This allows the community partners to not only exchange information at the point of care in real time related to a patient, but it also facilitates care coordination, population management, and analysis of clinical data for deriving intelligence from the system and identifying gaps and opportunities for action. The IT infrastructure also allows notification of emergency visits and hospitalizations to primary care physicians to help them play their role as part of the medical home for their patients and perform continuity of care by transmission of relevant clinical information from emergency departments or from inpatients to the primary care physician through the health information exchange, with the information going into the electronic medical records of the PCP. We complete the information cycle in terms of following the patient rather than just having information be siloed in different care settings. The other topic of importance related to managing chronic disease patients in primary care practices is the link with the specialty services. And so as part of our Beacon efforts, we have also created the infrastructure and the workflow that allows for electronic transmission of referral requests and documentation by PCP to the specialist, and then getting information back from the specialist with the consult summaries electronically into the EMR system. So while we focus on clinical transformation and care coordination activities in the delivery system, on the next slide we want to talk about our efforts in the Beacon program to test innovative technologies to engage patients directly or consumers in the healthcare process. And in order to achieve the goal of every patient in the community having an identified medical home to coordinate quality care, we needed to engage those who are not currently linked to the healthcare system. So we decided to use text-based technology to develop a campaign that encourages the general public to assess their risk for diabetes using their cell phones and then be linked to appropriate healthcare resources in the community for screening, diagnosis, and treatment. By the way, if people have heard of the Text for Baby national campaign, that was kind of the precursor on which, the framework on which we built Text for Health campaign. So we are partnering with 2 other beacon communities in Detroit and Cincinnati and have launched this Text for Health program end of January this year in partnership with the Office of National Coordinator for Health Information Technology, the Centers for Disease Control and Prevention, and the American Diabetes Association, along with a long list of local partners to understand the best way for a national spread of using text technology for public health programs for consumer engagement. We have currently close to about 1,000 patients who are enrolled during the first 3 months of the Text for Health program, and we plan to reach 5 times this number by the end of this year. So next slide. Finally, we have worked with our community clinic partners, mainly community health clinics, including federally qualified health centers, to make sure that primary care plays a key role in our system of care for patients with chronic conditions like diabetes and cardiovascular disease. These activities include holding clinical quality improvement work groups with clinicians from different clinic partners to discuss the challenges for implementation in their environments, sub-awards to promote quality improvement programs in different clinics, clinical seminar series for sharing best practices in the community, a centralized registry and care management capacity through the Health Information Exchange for population management, and finally practice coaching programs that Maria coordinates with about 20 different practices. So now I will transition to Maria Ludwig to talk about another key aspect of this program, which is the topic of today's seminar, how information technology and electronic medical records may help practices achieve and maintain patient-centered medical home and NCQA certification. Maria?
Thank you, Anjum. I'm going to be talking a little bit about the New Orleans area and the safety net system that our providers are targeted. To provide a context for our work, it's important to note that Louisiana and New Orleans continually rank at the bottom of national statistics for health outcomes. We have very high adult and infant mortality rates and a heavy burden of chronic disease. And as Anju mentioned, especially in the areas of cardiovascular disease and diabetes, which I know most of you associate with the New Orleans lifestyle of good food and good times. We also have high poverty rates, and about 40% of our population is living without insurance. Before Hurricane Katrina, we had a very broken healthcare delivery system. It was two-tiered and a high reliance on the emergency department by our uninsured, and we had definitely an insufficient capacity at the community level for primary care. And it resulted in a delayed access to preventative care and services and chronic disease management, and that fed directly into our health outcomes. In an awkward way, Hurricane Katrina provided us with an unprecedented opportunity to really rethink the way that healthcare services were made available to our very vulnerable uninsured population. And in 2007, a very large federal program came to the area to stabilize and expand the primary care infrastructure. And it began our transformation to a more community-based primary care medical home model. And we used the funding and our funding protocol to incentivize increased access to care and higher quality care. Our developing system was very fragile because it was very much reliant on that federal grant funding. And as that program was coming to an end, the state recognized how important these services were, and that they put forward an 1115 federal waiver to cover this population and sustain this network of primary care providers. to enable us to really transition to a more stable funding source through health insurance expansion in 2014. So we also were recognizing that the way of the future in 2014 would really look at quality, and that would be monitored by all payers and incentivized by all payers. So we really wanted to keep our transitions in the New Orleans area going. Through the Crescent City Beacon program, we've been able to maintain technical support and assistance to these same primary care practices that were funded under these federal programs. We're providing, as Anjum had mentioned, patient practice coaching with these providers, as well as these other programs that we're going to be discussing here, especially around HIT optimization. So we have 18 primary care practices representing 12 organizations, 60,000 patients, and quite a few providers that are operating in relatively small provider practices. Our types of providers range from federally qualified health centers to faith-based providers to academic medical centers, as well as very small grassroots post-Katrina healthcare providers that came on the scene and really responded to lack of health care in specific neighborhoods. So we have a very diverse group of sites participating. Additionally, through our federal program, we set aside $4 million that enabled us to incentivize practices to go for NCQA patient-centered medical home status. So in 2008, we had 13 practices that underwent 2008 standards and were recognized as patient-centered medical homes. One of the facilitating factors for the project that we're talking about today, the patient-centered medical home mapping initiative, was that we had all 13 practices were up for renewal in 2012. So we really wanted to take advantage of the Beacon initiative and to really focus in on how we can really think about how health information technology, in particular EMRs, and the health information exchange is going to support the patient-centered medical home approach. In addition, we have, through Beacon, a 12-month intensive practice coaching initiative with a learning collaborative focused on chronic care management in these practices. And that really is an opportunity for us to really deep dive into how the practices are dealing with the protocols associated with how they manage their cardiovascular disease patients and their diabetics, as well as what the workflows are, how they're using the care teams, how they're using their EMRs through clinical decision support, disease registries, to really focus on providing better care. In addition, we're looking at the health information exchange to sort of round out that picture for chronic disease management and really help us enable to get a good handle on our patients that are transitioning from one level of care to another. The 2011 NCQA PCMH standards also require more population-based reporting, which we noted were some of the challenges that we were experiencing with our EMR. And additionally, when the Meaningful Use 1 product enhancements came out for the EMRs, we noticed that there were still challenges. They were not necessarily provider-friendly. They didn't support necessarily a care team approach to care that's supported in Meaningful Use 1 and PCMH. And additionally, our providers were also concerned with Meaningful Use 2 and how that would impact their workflows. Additionally, we noted that our vendors were very engaged in our community. I'm going to share a little bit about that, but they definitely were interested in continuing the transition to patient-centered medical home, having their software more patient-centric, not provider-centric per se, but that its ease of use by the providers facilitates that patient-centeredness. And then they too wanted to align with the Beacon initiative. And we have a super user very much engaged in our community and very much interested in being on the forefront and leading the efforts around health information exchange. So we were fortunate enough in our area to have one dominant EMR vendor that provides care to the largest number of patients in our region. This vendor, the product is Success EHS. 13 of our practices use that software. We do have limited users within Allscripts and one user in Prima, another software package. And pre-Beacon, we had a relationship with this vendor, the largest vendor. Here at LPHI, we did limited EMR support as the FQHCs were transitioning post-Katrina to electronic medical records. And then we also convened a users group in 2006, 2008 that really began to look at how the EMR was functioning. This users group, though, is very different from what we're going to talk about today because primarily we did not have the vendor at the table with us. Then it was our providers getting together and really discussing their workflow challenges, making recommendations for how they would improve it together in consensus, but not with the vendor present. So there was no accountability. There were no formal process for follow-up with the vendor. So what we're going to describe today is a very different approach that we took on how to engage a vendor in ensuring that their software is really meeting the needs of the patients and the providers. So I'm going to now turn it over to Dr. Ebony Price-Haywood, who will share our new approach and methodology on engaging the vendor on meaningful use of an EMR to support the patient-centered medical home.
Thank you, Maria. I'm going to shift gears and get into overviewing the logistics of the project, give you some updates on where we are now. But as Maria said, I think it's very important to understand the context in which we joined this project and the direction that we took to focus on system enhancements to improve our workflow. All of this came out of our PCMH transformation in 2008 to 2009 during that period when we were all new to this concept and we're moving forward with healthcare delivery redesign in the New Orleans area. But to understand why I, as an individual provider, took some interest in leading this project, I think it's important to understand some background about my work in this area as medical director for the Tulane Community Health Centers. We were selected in part as a pilot for this project because of our unique experience in having switched from one EMR system to another. We adopted EMR in 2006, and to be honest with you, initially our interest in this was sort of like hurricane disaster planning, where lots of providers had lost their paper charts, and so obviously it made sense to get on an EMR, especially if it's web-based, so that patients can access it when they evacuate. But the truth of the matter, obviously, there are other reasons for using HIT, and so we were early adopters in this process. But after going through the NCQA recognition process in 2008, we realized that there were some system deficiencies that we were dealing with and really had to make a hard decision whether or not to stick with that vendor or to switch to another electronic medical record system. Going from paper to electronics is one process. Switching from one EMR to another is actually quite more difficult than I had anticipated, but as a practice, we thought that it was worth doing it for a variety of reasons. This decision to switch our EMRs also occurred in the midst of meaningful use discussions in 2010, and we happened to be selected by the Louisiana Healthcare Quality Forum to be a pilot site for an AHRQ-funded project that focused on examining how practices translate clinical guidelines into clinical decision support rules. The gist of that project, it ended up being very frustrating for me as a small clinic site, as well as another pilot site that was hospital-based. In the end, our conclusion to AHRQ was that unless the EMR vendors are engaged in software development initiatives that facilitate client adherence to HIT implementation standards, it's kind of pointless, to set national standards for us to adhere to that when we're limited by the software that we're using. Interestingly, as Marie had mentioned before, we also were just made aware of the new NCQA guidelines in 2011, and all of our sites were up for renewal again. We had managed to engage our vendor in the AHRQ project, and we felt that this PCMH project was a natural extension of that work that we had done previously. And so it was really through the AHRQ project that we were able to engage the vendor and garner their interest in us as a community that could help them improve their software and get them more in line with PCMH standards as well. But I think as a community, it's important to understand that going through this process of PCMH transformation, we had to do an analysis of the impact that HIT has on our workflow efficiency, and we naturally used the NCQA standards as a framework for doing that. But in the process of mapping out software deficiencies that were relevant to our workflow around the medical home, we realized that we were revising and creating workflows trying to maximize adherence to the standards, but really in essence develop multi-step workarounds. And there were 4 big areas where I think most of us, regardless of what system we were working in, realized that there were some major areas of deficiency. The first of which deals with access and communication. For example, being able to track response times to phone calls, having a way of assessing access to appointments to the third next available appointment. Of course, lab and referral tracking is a big issue for most practices, and that really speaks more to the interoperability of your system and how was the system designed to allow the care team to organize their tasks. Population health management and care management are also big areas. Most often the vendors think that because they have clinical decision support tools or patient registries that translates into care management, but the truth of the matter is that's 2 very different concepts. And one of the struggles that we've always had was how do you adhere to some of these care management standards when you don't really have the technology to support you in doing that. The last piece deals with performance reporting, and I'm sure most of you are aware of the different vendors. There's this wide range of what's available to you in terms of being able to create reports. It's either very simple or it's very complex, and it requires different levels of users to be able to adequately use whatever tools are at hand. So as I mentioned before, in doing this assessment of how we're using HIT, we discovered that our EMRs had a tremendous amount of deficiencies that led to workflow inefficiencies. As I said before, multi-step workarounds were noted within all of the different systems that were being used locally. So it didn't matter if there were a majority of people on one system versus another. We all found problems with our system. The other interesting thing is that the users who were using Success EHS and had come together in a work group, the interesting thing is that they had all created different types of workflows working within the same system. The other thing is that among the end users of the same vendor, various clinics had mastered the system differently. And so what it revealed was a big gap in knowledge and skill sets across the different practice organizations as well as the different individual users. As mentioned previously, in 2008-2009, Success EHS work group had come together with the objectives of determining what are the best practices in place with the system limitations as they were at that point in time. The other piece of that was to share our workflow analysis with the vendor and then make formal recommendations for system redesign. The problem, though, was that the vendor was not engaged actively at that point in time. The challenges that we then faced as a group was coming to consensus on prioritizing requests that were made to the vendor. As I mentioned before, different users are at different stages of use of the system, and coming to a consensus was a bit of a challenge. The other piece of that was response time of the vendor to suggestions. I think as end users, we expect that if we make a suggestion that it will be adhered to or corrected in a short time, but the reality is from the vendor standpoint that software development does take some time. So there was issues from our perspective in terms of how timely their response was. As mentioned in the previous parts of the presentation, there were, however, some external pressures on a national level that I think allowed us to get the vendor engaged in further. So initially, the vendor was engaged with my particular practice site, but there were reasons for that vendor to engage with the rest of the New Orleans community, the first of which was obviously the Beacon program, the second of which was the high-tech legislation that came out, meaningful use, and the third piece of that had to do with NCQA realigning its standards with the meaningful use standards. On the next slide, this is just an overview of the 2011 NCQA medical home standards, which I won't go into detail other than to say that there are 6 standards, of which there are 27 elements, and each of those standards is associated with a score that is then used to determine the 3 levels of recognition with NCQA. The details of that is beyond the scope of the presentation, and NCQA does provide a detailed manual, but the key piece for us in going through this process was that NCQA provides a crosswalk of meaningful use with some of its standards that are embedded within the new, the 2011 standards. And for us, I would say that it was a bit overwhelming if you went through the 2008 process and then looked at the 2011 process. I think we all sort of threw our hands up in frustration and didn't know, how would we renew under those new circumstances. So on to the next slide, I always use this quote because it was very timely and I think explained some of the frustrations that we've had, which is that while health IT per se is unlikely to lead to better care, but health IT, if built and implemented and used in a meaningful way, is very likely to result in better care. And I think this expresses a lot of a sense of futility that we had, and that the challenges we had with our current systems were likely to be even more difficult unless the EMR vendor realigned their products to facilitate customer adherence to both medical home standards as well as meaningful use standards. But to our knowledge, there was no current process for certifying EMR to be a PCMH or to help clients be compliant with PCMH standards. And although there is a process for certifying in meaningful use, sometimes for us it was somewhat of a joke, to be honest, because there are some things that the vendors could have done to meet, like, a checklist of meaningful use standards, but from the end user standpoint, it wasn't very meaningful. So just because it was certified doesn't mean that it was built in a way that made sense to the client. So with these external pressures, we actually regrouped our work group, end user work group, and redesigned our tasks. And the most important thing was that the Crescent City Beacon Community Initiative served as a platform for unifying the customer voice. It was a way of basically convening us in a way that I thought was more powerful than we'd had prior to the Beacon project. We also, as a group, decided to realign our suggestions for EMR product redesign or upgrade with the NCQA standard and meaningful use workflow. And it really made sense because we had already gone through that process internally. And then finally, not only did we want to work with the vendor to make upgrades for our own benefit, but we were really interested in developing a toolkit that would instruct other clients on how to use the new system updates to facilitate adherence to medical home standards. So how did we do that? So in July of 2011, we assigned a project team, or developed a project team, which included myself as the community super user lead, members of the LPHI, Louisiana Public Health Institute Chronic Care Management Project team, and also and the vendor. And as you can see from this slide, there were all aspects of the vendor were engaged in this process. And so this is actually exemplary of how important it was to the vendor to partner with us on this endeavor. After getting the team together, our next step was to create a worksheet using the NCQA standards. And I'll show you an example of that in a minute. But the point of the worksheet was to highlight various definitions as outlined in the NCQA manual, also define what reporting requirements were needed for each of the individual elements and sub-elements, go through the current EMR workflow, assessing the modules that are in the system and the functionality, and then reviewing the system capacity, especially with respect to our ability to collect and store the data in the right place and be able to retrieve and report out on that information to NCQA. The next slide literally is a snapshot of the Excel spreadsheet that we made for mapping the standards to the EMR features. And on this slide, it's focusing on Standard 1A, which is dealing with access during office hours. So we literally broke down each of the different individual components of the NCQA standards, decided or what type of information was needed for reporting in terms of clinical protocols, looked at the EMR functionality required and determined whether or not it was present, so yes or no, looked at EMR functionality as to whether or not it existed, and if we weren't quite sure, as you can see in this slide, for the patient portal features, there was a question of whether or not we were able to capture communication back and forth through patient portal, so that was something we brought to the vendor's attention. Also, we indicated the various modules within the system where the functionality was currently stored, and then the most important part for me was whether or not the information was extractable and reportable, since, as many of you know, there's a lot of data reporting for NCQA. So this is sort of a replication of that information, but for each standard element and factor, we actually work with the vendor to test the system capacity. We identified workflow challenges that we gathered from the different practices. We developed recommendations for system enhancements, and we also developed a list of standardized reports that we thought were important for the end users. It was very important to engage the entire community using the software. So we had a 2-day kickoff meeting in August of 2011 in which community providers were represented. So there was clinical and practice management super users, as well as a variety of different care team members. And the point of that is that often there's a heavy focus on the physician perspective in the system, but I think it's important to include all members of the care team and to also focus on both the business and the clinical side of the system and engage those folks in the process of doing an assessment of the system. Again, the chronic care management project team joined the meeting, and the senior members of the vendor also actually came to New Orleans to meet with us face-to-face. During that time, it gave us an opportunity to review and provide detailed feedback on some of the system enhancements that the vendor had suggested, some of which, quite frankly, didn't make sense to us, so we told them it didn't make sense, and they were actually very open to that. Thereafter, the project team conducted weekly calls with the vendor, and every now and then we would add in another advanced super user from a different clinic so that it wasn't just my opinion that was used in these conversations. And during those project calls, we refined some of our previous requests for software enhancements, went through very detailed clarification process with the vendor, and also started testing the functionality. By December of 2011, the vendor released its first round of system enhancements, and those enhancements pretty much fell into 4 major categories. The first of which was to help us organize data display. I think one of the most challenging things when it comes to lab tracking and referral tracking is to have just a massive list of orders that you may have put in, but it was important for us to understand what's the status of that order. Are they resulted? You know, has an appointment been made for a subspecialty referral? So we actually worked through how to capture those different phases of an order process so that it can display a certain way and organize the data from the end user's perspective. Again, it was important to capture data in a reportable format. Primary example of that was being able to capture response times to medical calls. So there was some modification of the medical call tool that the vendor implemented by December. The other piece that I think is important to most of us is to reduce the number of steps just to document a process. And an example that we did was for care management. We created these templates, and the vendor embedded coding within those templates so that they would link out to another document that we call the care plan form, that if a nurse or a provider typed into this template, the information would naturally flow and you can print it out at the end of the visit and give it to the patient as opposed to typing it twice in 2 different places. And then last but not least, we had to build standardized reports that needed to be imported into the various systems for the sake of making sure that if we are putting data in the same places, be able to have a report that will actually pull out the data accurately. That's all assuming that you're storing the data in the same place, so it's important to work through that. So the toolkit, in order to try to help make sure that we standardize process across different users within the same vendor, what it does is it literally reviews the requirements for documenting adherence to the NCQA standards. It provides detailed instructions to standardize use of the features and system enhancements to implement the PCMH standards, and again to capture data for reporting. There were also templates that the vendor, initial round of templates that the vendor came up with that were automatically imported into the systems that the clients could then go in and pull the reports and pull data. And there were also sample policies and procedures from NCQA recognized customers that we shared. I mean, if you're familiar with NCQA, you know there's a lot that goes into documentation, job descriptions, policies, and things like that. And so we thought it was important for other clients to be aware of that. So in terms of our next step, obviously anything that's developed needs to be tested. And so we're in the midst of beta testing the system enhancements. And the key part of that is to examine the experience of the customers with respect to the software. One of the things that's really important that we learned in this process is the perception of an advanced end user versus what we would call a typical end user is very different. And I would imagine that the typical user may actually benefit more from the toolkit than those who are advanced and expecting a lot more from the vendor. But to be honest, much of what we did was tailored towards the typical user, not the advanced user. The other thing was to understand these enhancements, did they actually reduce or enhance the workflow, increase efficiency for the different care team members, or were we kind of creating yet another set of workarounds and not realizing that that's what was happening? Obviously, the goal was to cut down the steps, so we need to do a detailed analysis of that. And finally, as was mentioned earlier, in 2012, most of our sites that were previously recognized under NCQA expired in January of this year and are up for renewal. So this is an opportunity for us to take the toolkit, work with those partners, going through the process, and be able to actually measure how well the toolkit helps them in achieving certain goals. Obviously, we want everyone to be a Tier 3 medical home, but the point is that's not really the point of it. The point of it is to help them improve their workflow and improve their use of the system and standardize how we use the system across the different users. So with that, I'm going to turn it back over to Anjum for some closing thoughts on our project and the work that we've done over the last 2 years.
Thank you, Ebony. This is just this great work that Ebony has done in collaboration with our vendor and also with a group of providers in the community in New Orleans. But as you all see, when one thinks of improving the system of care in a community, each aspect of the delivery system has to be studied and worked on in a manner that is integrated with other parts of the healthcare system. And the PCMH work that Ebony has spearheaded in the community in partnership with other providers and with a vendor is a great example of public-private partnership that focuses on using health information technology as a tool that facilitates the work of clinicians and providers for the benefit of patient care. Optimizing the electronic medical record systems to provide patient-centered care while using information collected at different points of the system is made possible by the Health Information Exchange, and the use cases are developed in collaboration with providers and clinicians in the community. So as a community, we are very excited about these changes, and will continue to report and share the impact of these changes on population health and patient outcomes. Again, we are all very thankful to the Office of National Coordinator for Health Information Technology as our partner in the Beacon Community Program, and the Patient-Centered Primary Care Collaborative for having given us this opportunity to share our experiences with all of you. We'll be happy to answer any questions that you have. Thank you.
Great. This is Chris Norden back again. Thank you, Anjum, and thank you others on the call for your very candid comments today about the wonderful successes that you've had with your HIT integration at Crescent City. And this is now the portion of the program where you have an opportunity to cajole and provoke and ask interesting questions, or get some clarification of things that are on your mind, and draw upon the expertise of the people that we've had in front of you now. I want to remind you that if you want to ask questions, to go over to the drop-down box along the right-hand navigator column and enter your question there. And we won't necessarily take them in order, but we'll try to get through as many of the questions as we can in the remaining half hour that we have more or less in front of us. Is Craig still on the line?
Yep, I'm here.
Oh, great. Craig, I think the first question that came in, I think, may be in your bailiwick, and it's asking about the ONC PIN 003 requirements, and if you can tell us what those are. But they want to know, the questioner wants to know if they will apply to the Beacon community participants as it relates to aggregation of data and the newly minted HIT obligations that go beyond HIPAA. Is that something that you would like to tackle?
Well, let's see. Well, I believe what the questioner is asking about is our recent notice about the Health Information Exchange Program and policy around privacy and security. And so the short answer is that the Beacon communities are tackling this in different ways, but they are have been given similar guidance. They're not. We're not quite as heavy-handed. Well, heavy-handed is not the right word. We don't quite dictate some of that aspect of the work in the Beacons as much as maybe in the state program. But that's this is a pretty technical issue, and to be honest with you, I'm not the guy to really go deep on that one.
Okay, great. Thank you for that. The next question is about pediatrics and where the pediatrics fit in the role of care at Crescent City and with your practice transformation. And I wondered, Maria, if you might want to start with that and perhaps direct it to others on your team.
Certainly around our providers are also pediatric providers as well, and we are using the same methodology around pediatric care. I know Dr. Price provides pediatric care in their practice, so I'll ask her to speak to that.
I mean, in our role, in our experience, everything that we do for the adults, we pretty much have parallel policies and procedures with the pediatric population. And in our case, we're in the same database, in the same, using the same vendor. So all of the issues that I've talked about today are relevant to the pediatric population as well.
Okay, very good. The next question, I think, was mostly answered by one of your slides, but perhaps you may want to add additional clarification if it's needed. And that is, what is the most common EMR vendor that you're using in your participating practices? And I think that I saw Success, EHS, and Allscripts and Prima pointed out. Are there any other notes you might want to make about that, Dr. Khurshid or Dr. Price, Saywood?
Success EHS is the largest vendor here. I'm not sure besides the three, are there any others represented? There are some of our partners who are actually adopting some other systems like Epic, our hospital partners. But those are really, I would say, the four. But the CEHS is the biggest, has the largest clientele.
Now, we have used the worksheet with other vendor products, and it was used by the group who's using Prima, and it's just now being launched with Allscripts. So we are trying to replicate the methodology and approach that we took with this with the other vendors.
Okay, very good. Question about the costs of the vendor interfacing, both to and from the practice, physician practice EMR systems. Have you shared that information about the costs with the ONC, and are you able to share it with this audience?
The cost around the health information exchange, or around the...
I think it's just the interfaces for data sharing, so that would touch some aspects of the HIE, yes.
Mm-hmm. I'll have to defer to Anjum on that.
So there is one cost for the establishment of the health information exchange, which of course varies depending on what services are required. But I think the question is specifically for the interface with the EMRs. For a lot of the work that was done in this partnership with CEHS, I think one of the good aspects of this work being seen as a partnership was that, for instance, when the team of EHS users came, EHS folks came to New Orleans, some of it was basically the cost was funded by the vendor themselves. And through the Beacon Community Program, though, we are helping establish interfaces with the EMR systems to integrate the EMR systems in the community so that data sharing can take place. And that cost varies by the number of interfaces, the amount of development work they have to do. There are many other technical aspects that are related to individual costs for interfaces. With our selection of the HIE vendor, one of the advantages we had was because it's an open source platform for Mirth that we are using the vendor, that the interface costs are somewhat reduced, and we have our own developers that can help developing interfaces moving forward.
Great. Can you tell us a little bit about the different kinds of transitions of care that are supported by your network electronically?
So this is Anjum. So we have, when we think of transitions of care, I think there are several features that all come under transitions of care. Whenever patients are going between different care settings, the fact that information should flow with the patient is something that we want to establish in the community. So the two specific use cases that we started off, again with the thinking that these are just the first two, but there will be many more applications, is ED and inpatient notifications, because in terms of providing continuity of care at the primary care setting, one of the biggest challenges for primary care physicians, especially with the safety net practices, is not knowing when their patient went to an ED, not knowing what the chief complaint was, not knowing when the patient was discharged from hospitalization, what were the discharge notes. So that was like the first use case that we focused on, to be able to get that information to the primary care physician as soon as that event takes place. And similarly, the second part of this was, as we looked at, again, focused on the role of the primary care practice as a medical home, as the primary care physician directs the care to some extent, or helps the patient connect to a specialist for consultation, that there is information flow and bilateral information or bidirectional information flow between the specialist and the patient and the primary care physician to make the care continuous and effective. So those are the two major use cases for transitions of care that we have started with, although we foresee that we'll be using this for other transitions as well, which is for, say, nursing care and other services.
Great, thank you. Tell us a little bit about the type of care management software that you utilize to manage chronic care, workflow in particular, or is this just another module within Success CHS?
Well, this is Ebony, but actually part of the problem that we run across with all of the vendors is that there is not a sufficient care management tool embedded within the EMR. And often what you'll find is that there, like I said, clinical decision support rules and patient registries that are generated, but in terms of how those registry functions, how patients get into the list versus fall off of your list, the different tiers that a patient may move from based on whatever the clinical decision support rules are, or the details of those rules, it's been very difficult for our care managers to have a snapshot of the patients that they're taking care of. So if we have a standard protocol, say for diabetes, that there are certain things that we're supposed to do and document a certain way, there's no way for the care manager to just go into the system and get a snapshot of that. That is I would say, a major deficiency of all the softwares that are currently being used, which is in part why a lot of the customers, local Beacon partners, were excited about this MIRF product, because it's not just a health information exchange tool, but it also is a way, it has a care management tool embedded within that exchange software that some of the sites are planning to use. The only disadvantage with that we're trying to figure out is no one wants to document things in two different systems. So even though the MIRF product gives us a tool that helps give the snapshot that the care managers need, one extra step that we have to work on is how do we push the information from the exchange system to the EMR so that, say for instance, the providers can see what's happening with individual patients as opposed to logging in to get another system. So that's actually a major challenge that we continue to work with.
Yeah, sounds challenging. How do the various EMRs in your network accumulate and communicate the quality measures to the Beacon participants and back to your central operation?
So we do a lot of work on data standardization within the systems and then having their own report writing capacities within the EMR systems right now. But eventually, I mean, within the health information exchange, we'll be pushing that information directly into the analytics and have access to it through analytics from the MIRF care product, for the MIRF product.
Great. Lots of questions about your great Excel spreadsheet, whether that could be made available either online through the slides or by request through email. What are your thoughts?
We don't see a problem with that.
Okay. Would you prefer to have people contact you individually, or would you like us just to include that with the slides when it goes up on the PCMH website? What would be appropriate?
Probably easier if we upload it to the web.
Okay. Great. I think there'll be a lot of utility for that. Certainly a lot of interest from the number of questions that have come in on that. Who is the vendor for your PCMH toolkit?
Success EHS.
Oh, okay. Great. And can you tell a little bit more about, in a little bit more detail about the care plans that you're generating? What types of things are you tracking, monitoring, reporting? I think you touched a little bit on that.
Yeah, there are some that we did with a Beacon project, and then there's things that individual practices are doing on their own. But for the Beacon project, there was a diabetes care plan template that we had a care management work group get together and determine which aspects of care management they wanted to make sure that we standardize across the different practices. Not really sure how well that's being adopted in the different places, but the way the care plan template works is there's something called patient correspondence forms that we use. It's just like not a Word document, but it's a document where you can create, type up however you want to display your information, and then use merge fields like for medications or lab results or that sort of thing into the care plan template, so that when you go into that patient's record and you open up this template based on the merge fields that you have in there, it'll display certain information that you can then give to the patient. Another aspect of the care plan template are individual goal setting or instructions. So we have diabetes care management templates within the EMR that the providers or the nurses or our clinical pharmacist uses, and there are sections where, for instance, you may set treatment goals. And so it's something that you can type into that section of the template, but that text box of the template can link back to the forms that we have, so that once the patient is discharged, the nurse can print out this form with merge fields that will have whatever components of care management related to the disease that we wanted to display for the patient, as well as their tailored goals that may have been set at that visit.
Mm-hmm. Great. So a good deal of it is then accessible to the patient in some sort of language that they can understand.
Right.
Exactly. Clinical. Okay. Great. That was a second follow-up part of that question. Can you elaborate on other sites besides FQHCs and academic facilities that are participating?
Sure. We have faith-based organizations that are participating that operate a number of sites. We also have very grassroots organizations that cropped up after Katrina using the free care model, but that have slowly transitioned into more traditional, or not more traditional, but more traditional fee structures associated with them. They, in general, we have mostly smaller practice sizes. I mean, we have, on average, I think there are 3 provider practice size. In general, they have physicians, nurse practitioners, but generally working at the same location, no standalone nurse practitioner practices here. They generally range from more comprehensive services that are available, like an FQHC that have dental care or optometry care, to just primary care. But many of our sites also were participating under the primary care grant in an initiative to improve primary care and behavioral health integration. So the vast majority, if not all of the sites, I believe, have some level of behavioral health care as a part of their care team structure.
Hey, Anjum, this is Craig here. You might want to mention some of your forward-looking work with Blue Cross Blue Shield and others in that market around using this sort of early work with a isolated cohort of safety net providers and expanding more broadly in the future. I know it's still early and you got a ways to go, but folks might be interested in your kind of longer range thinking to address the question.
Okay, thank you. As we were looking at all these system advancements and improvements, we are definitely keeping in mind the changes that are happening nationally and what we expect would be changes in the payment systems and reimbursement systems, not only with CMS guidelines around accountable care organizations and bundled payments, but also in the commercial market. So we have worked very closely with the Blue Cross Blue Shield of Louisiana, which is a commercial payer and one of the largest commercial payers in Louisiana, to start understanding how a system like this actually addresses the concerns that payers may have for the future of reimbursements of services when you are thinking of moving from a fee-for-service to a fee-for-value system. Actually, at the same time, what has been interesting is that Louisiana has moved to a managed Medicaid system as well, which again is based on the proposition of trying to manage populations rather than just having transactional reimbursement. In both these cases, the system that we are developing with our safety net practices, it talks about focusing on how can we use primary care practices as a pivot point, as a key point in the healthcare system to manage populations for improved outcomes, and then be able to develop a business plan that basically describes what is the value that a system like this with improved quality, access, and management of patients provides to eventual payers of these services. These discussions have just started in the last few months as we develop these systems and we're able to demonstrate some of the benefits for quality improvement that may happen in our patient populations, and also our capacity to be able to integrate and coordinate care across the community using the health information exchange and some of the changes in clinical transformation as have been described by Ebony and others, and seeing how we can transform the system not only to a safety net system but actually expand it to the private market as well, because these systems are needed and required to improve care and control costs and manage populations across the community irrespective of the insurer for these services. So we are looking forward to understanding some of these questions, but also building on the system that we are establishing, which allows us to measure and inform population health outcomes for improved outcomes in the future.
Yeah, great. Thank you, Anjem. Another follow-on question to that from another questioner is that they do recognize that your program is still young, but they're wondering if you are seeing any early trends that you might be able to share with us that suggest that the improvements that you're seeing may be related to your objectives, such as improvement of disease morbidity or lower costs. Anything you want to share in that realm?
So, Anjem, as people can understand, trying to change prevalence or morbidity at the population level is not something that can happen within months, and it usually takes time. However, I think what we are seeing and what we are optimistic about is some early trends in processes or process improvements that could be proximal determinants of some of these outcomes. So for instance, one of the things that just in the short period of time that we have tried to implement the system, we are already seeing is improvements in reporting of quality data, which unless we can measure these things, we can't really understand where we are and what we need to do to improve quality metrics. So we have worked very closely with our partners in working with their systems to see if, as was referred earlier, to try to help in some data normalization and data standardization as far as quality metrics and their reporting in the community are concerned. And we are very hopeful that with the systems that we are now able to measure some of these outcomes, that we'll be able to see what the impact of these system changes would be for patient outcomes. Because we have seen it in some other communities where the systems like this have been in place, where through the central reporting functions, and data warehouse at the HIE level, that we have the capacity now to measure those changes more effectively.
Great, thank you. Do any of you know of other vendors that may have already completed similar work that in the way of creating software that will facilitate the NCQA and PCMH model?
Not to my knowledge, but obviously we've only worked with a limited number of vendors, but as far as we know, no.
Oh, okay.
I think that, this is Craig, I think there are multiple vendors who have, who understand the NCQA guidelines and are trying to, design their product to meet those.
Great. Another attendee is echoing your comments that they are also using Success EHS and their EMR vendor together with them are applying for PCMH recognition. They're wondering if you're finding your toolkit to be especially helpful to provide the information that's needed to meet various factors.
I would say, in my head, the toolkit is still in beta testing, but from the different components of it, and this is something I tell the vendor, that there are a lot about the NCQA process. There's a portion of it that's related to the data. There's a portion of it related to demonstrating system capabilities and how the software works. There's a large part of it that deals with policies and procedures and other aspects that the vendor really can't help you supply the right amount of information. So we've tried to provide some of that with some documents that we have shared with the vendor, but we are actually in the midst of still reviewing the toolkit again to make sure that we have all of the components that are necessary, and to see if there's anything that we did not include with the initial rollout of the toolkit. So it's still under review.
Okay, understandable. Next question is quite interesting, and it may have some interesting tangents. You might want to chime in with your ideas on this. You undoubtedly found some challenges with building consensus among your providers when you were mapping their individual workflows, and how did you manage those differences?
That's interesting.
Yeah.
Oh, let's see. Well, I think, to be honest with you, I think the challenges probably were more so from the advanced users as opposed to what we call the typical users, because the advanced users have an in-depth understanding of the software, the good and the bad, and tend to be more vocal than I would say the typical users were. And so part of it was understanding that the vast majority of our group were typical users, and that the advanced users had to be sensitive to the needs of those groups to kind of help bring the rest of the partners up to the same level as the first stage. Simultaneously, the advanced users were having separate conversations outside of group conversations with the typical users, so that their needs could also be addressed, but within probably a different timeline compared to what we were trying to achieve for the typical users. So I think I had mentioned that before in terms of examining the experience of the two groups, and the reason why that was important is because I think the advanced users are typically the ones that are continue to complain, because what they're looking for is very detailed software enhancements that take a while. So it's going to take some time for development.
Yeah, great, thank you. There's a comment from Rick Moore, who is the CIO of NCQA, and his comment is that they have now pre-validated Vitel and Athena Health for PCMH requirements. So food for thought for those of you who are in the market. How have you incentivized your hospitals to participate in HIE and transitions and tracking?
Anjum, do you want to take that one?
Okay, yeah, sure. So we have been, the hospitals in our system, in our area, were involved in Beacon program ever since we applied for it. So they were all on the table, and they were talking about this and understood and felt the need for the kind of health information technology solutions that we have come up with in the Beacon program. What was particular about the way that we went about developing the HIE in consultation with actually our hospital partners was that we started with the focus on connecting the primary care practices together through the HIE and then connecting them to the hospital for work that was mostly focused on primary care practice. Most HIEs are established usually the other way around, where they start with connecting hospitals and then they connect practices as part of that effort. And the other thing that was also peculiar about the way that we approached this, again in consultation with our hospital partners and primary care partners, was that we focused on not only on the connectivity or the infrastructure, we actually focused on the use case and what this information exchange will be used for. And hence you see we have gone for solutions that allow for care management, community-wide registries, and those functions that help us bring use cases into action in the shortest period, rather than focus on just connecting a lot of sites for exchange of information at the point of care. Now what has happened is for transitions of care, then we have started with pilots within single hospitals so that we can understand the workflow and establish those workflows. And much like this project, like having a workflow that has been tested and then that can be then expanded to other hospital partners who are on the table and participating in evaluating these pilots and seeing how we implement them in reality. Because with, for instance, ED notification, it is not just a matter of sending a notification from emergency department to a primary care. We have to understand who sends it, when do they send it, who receives it, and what happens when it is received. So unless we understand the entire workflow, the impact of ED notification and the use of the health information exchange would not be there. So that's how we have proceeded, which means that the hospital participation has been more around use cases and very focused rather than a very open exchanging all information with the exchange.
Great, thank you. Another aspect of exchange is our other state health agencies, and Jim, and perhaps you'd like to try this question, and then if others have other comments to add to it. The questioner is wondering if you've worked on HIE with your state public health programs, such as the State Immunization Registry for Preventive Care, or facilitating transfer of state newborn screening results, and so on. Are these in the offing, or long range, or short term?
Yeah, excellent question. And it's for sure a part of the state HIE program. And the way we have structured our health information exchange is that we will be connected to the state HIE for a bilateral exchange of bidirectional exchange of information. So when the state gets this information, our providers in the New Orleans area would also have access to this information. However, we are working with the city health department and also with the Department of Health and Hospitals for connecting to other data sources in the state that can facilitate the care process for our patients. For instance, there's a state program on low birth outcomes that we are talking to them how mirth care and the HIE can facilitate case management of women who are at risk for complications in pregnancy, for improved outcomes with them, and to be able to track that within the healthcare system. So those are definitely those conversations are taking place, and we have the capacity to get that information, and the efficiency of this infrastructure and the role that health information technology plays in improving the efficiency of the system as a whole is that now these 18, 20 practices and more, as we expand further, who are connecting to the Health Information Exchange do not have to connect to these state-level systems one by one on their own, but their connection to the HIE actually provides them access to these services. We just had a call this morning, for instance, with one of the patient assistance pharmacy programs, again, how they can connect to the HIE to be able to provide services to patients that are seen by all the different practices.
Hey, you know, Chris, let me just mention, too, one of the exciting things to see in New Orleans as well as in many other communities that we work with is this linkage with state policy. So in the case of the New Orleans Beacon team, Secretary of Health Bruce Greenstein for the state is very, very engaged in this work, serves on a senior leadership committee that includes two others, one a senior executive from Blue Cross Blue Shield and a third from Karen DeSalvo, who's the governor or the mayor's, I guess, health
commissioner.
Yeah, and so it's really been a terrific example of community health leadership, the health commissioner, state health leadership, the health commissioner for the state, and private sector leadership coming together to really think smartly about how to do this kind of work. So this community and many others that we have the privilege of working with are very well attuned to making sure all these oars are kind of rowing in a similar direction.
That's wonderful. Yeah, that's a great point, and thank you for that, Greg, and probably a good point to start wrapping up our discussion today. And I want to thank the team at the Beacon City Health community for the wonderful presentations they've brought us today, and I'd also like to thank Craig and Christina for the national leadership that they've provided to make this all possible, and the funding that has come along with it, and I hope the next 2 years are equally successful. Craig, did you have any further comments you want to make on closing?
No, just thank you all for the opportunity to talk about this great work. Watch this space. Lots of great work coming out from the Beacon communities to come.
Great, thank you. Final plug, our next Center for eHealth webinar will be on Tuesday, June the 12th. If you'd like to mark your calendars, it'll be from 1 to 2:30 p.m. and we'll be hearing from Kevin Dorrance, Commander Kevin Dorrance from the National Naval Medical Center, talking about some of their HIT successes for proactive primary care. So thank you all and have a wonderful day.